Hi, thank you so much for being here. And it's a real pleasure to be back to this conference. And I'm going to talk today about a big program of research that I'm involved in the UK, funded by the National Institute of Health and Social Care Research. I was imagining like a smaller room and more interaction, so I think I know a bit about you. I will try to touch on the wonderful questions that you all asked as well in what I'm going to say now, because there are some, I think, points of contact. And I'm a researcher, but I'm also a lecturer, so half of my work involves working with master's and PhD students, and the other half is doing this research. So for this session, I think I'm going to introduce the topic. So my focus is healthcare professionals' well-being and mental health. As I was saying, the Care Under Pressure research program has been going on since 2017. I'm going to give a little bit of background, but I'm going to focus on the latest arm of the project, which is Care Under Pressure 3, which is currently ongoing. So I wanted to share some, current research results. The focus is hospital doctors. So I'm talking about all specialties in hospitals, so in the workplace, and that's going to be important. I'm going to say why in a second, and in the UK. I was thinking how to make this session more interactive. I guess I will try and make it as engaging as possible to show not only the academic outputs. We've been really trying to lead to change in a kind of evidence-based way. So we have produced also creative outputs like cartoons, animations, and if there is time, I will try and show some of those. So, background. Healthcare professionals' poor well-being is a global and really pressing concern. It was already before the pandemic, the COVID-19 pandemic. The pandemic put it, cast some more light on the issue, but I think the light is fading already. And it's a very prevalent problem across any profession in healthcare, any specialties, and throughout careers. So it starts from medical training, and then it continues until retirement. In the UK, it's quite interesting that it's been referred to as the biggest internal threat to the sustainability of the national health system. And of course, you can see how, if you take like a system lens, if there are issues around poor well-being and mental health, this has an impact on recruitment of healthcare workforce, workforce retention, so people will leave earlier. And then there may be issues around absenteeism, so taking long or short absence from work, presenteeism, which is also quite dangerous, so working well and well. And this can have a huge impact on the delivery of complex and excellent and equitable care. So the WHO around 2016 was talking about the triple aim to deliver excellent and equitable care. It was around the ratio of healthcare professional workforce against the patient population. Thankfully, there's been also the idea of adding like a fourth aim, which is the well-being of healthcare professionals as something underpinning the three aims of healthcare. So in a nutshell, the idea is that there is no health without a healthy workforce. So not only having a healthy workforce is a value in itself, but it's at the basis of what all of you do as well in genetic medicine, but in general at the basis of what medicine is doing. So it's a very tragic irony if the workforce is kind of suffering, experiencing mental health, burnout, and all these issues while trying to deliver care. So this, I think, is quite helpful. So far, I mean, even before the pandemic, there is a major tendency to see these issues as individual only. And the whole idea is to think about how can we make individual more resilient, or how can we increase the productivity of the individual doctor. But this is a very complex problem. So complex problems require a kind of complex approach, and I think you're very familiar with complexity being in genomic medicine and research. So there is certainly an individual level, but there are also organizational. There can be aspects related to learning and the work environment, broader sociocultural issues. Sandra was talking about like imposter syndrome, but some of these things may be professional. There may be like a hidden curriculum. how the training is also organized. So there were interesting questions about the individual level is really important, but if it becomes the only way to understand and to address the problem, it can exacerbate the pressure that doctors are experiencing, because there are a lot of other issues that are creating a toxic environment. So in a way that is linked to one of the questions that was asked earlier about the broader system level change. There was another question about neurodivergency. If you think about it, a lot of potentially faculty can be neurodivergent as well. So there is a need of support, thinking about relationally as well. So how the faculty can be not only trained, but also can understand and can have support to be able to help students and any students in medicine or in other professions. So it's quite important to understand the complexity of the issue, the causes, and how they may be interrelated. And so this is, we have been using a realist approach, which is like a methodology that is used to make sense of complex interventions and strategies. And the whole idea is that there is no one-size-fits-all, but there are certain policy or certain intervention or strategy that may be more or less likely to work in certain contexts. So the whole point is to understand not if something works, but when, how, why, for whom. So it's a more nuanced way to make sense of complexity and of strategies to improve any situation. So I was saying, I'm going to talk about current under pressure 3. There's been a lot of caps. So the first arm of the project was an evidence synthesis, like a realist review of all the interventions that were developed to understand the causes of mental ill health in doctors across specialty and career stages, and any kind of intervention in order to make evidence-based recommendations. And that was current under pressure 1. Current under pressure 2 applied the same method, so it was a realist review of intervention, but the focus was nurses, midwife, and paramedics. And I can't list all the publications, but I can signpost you to the web page. And, whoa, okay, so, and you can see, if you go on the resources, you will find all the publications that are all open access, but there are also cartoons, animation, and other things that we have tried to create to translate our findings in something that you can all use. So you can also use cartoons, and all this, they're all free for you to spread if you find them helpful. So current under pressure 3 is the current project. So optimizing the delivery and impacts of intervention to support hospital doctors' mental health and well-being in the NHS. So one of the things that we realized when doing the current under pressure 1 is that there are so many interventions already existing, but they're not working. So the point was, rather than thinking about creating more and more new interventions, how can we improve what exists already, but in an evidence-based way? So this is a collaboration between Exeter, like where I'm based, Hull York Medical School, University of Oxford, one of the Devon Partnership Trusts, so one of the hospitals, and again, funded by the National Institute of Health and Social Care Research. If you want to tweet, that's the handle they care under, this thing here, and then, yeah, the website again. So I can't list all the team members, but just to point, because of the complexity of the issue, whoops, wrong button, so it's a blend of backgrounds: medical education, social science, health service researchers, a lot of different doctors from different specialties and different career stages, implementation scientists, people with methodological expertise. So yeah, that's the only thing I'm going to say about the team. The aim, as I said, was, is to work with and learn from 8 NHS trusts, so that's how we call certain hospitals in the UK, to minimize doctor mental health and its impact on the workforce and patient care. So we selected these 8 trusts strategically to maximize scope for contextual diversity. So different size of trust, patient population served, how well and less well they were doing in terms of staff and doctor well-being. And we had 3 main phases. The first phase was to develop a typology of interventions to reduce mental ill health, and use this, we used that to help the selection of the trust. Then we worked with these 8 trusts to understand their existing strategy and what is working well and less well and why. And then we are distilling all this lesson learned from this trust, our previous evidence-based synthesis, to co-create with them a guidance to help any hospital in England to implement whichever strategy they've got already to reduce doctor mental ill health. I think actually, yeah, so terminology is also very important. It's kind of linked to one of the points that Sandra was making about words. So we are trying now to think in terms of well-being and mental health as broadly as possible. So anything anything that can promote well-being to anything that can cause mental ill health problems, can be stress, burnout, or traumatic event in the workplace. And this is linked to the fact that when we think about intervention, we're thinking very broadly. So from prevention to treatment. So anything that can improve personal resources, which are things that Sandra was covering, but also things that can improve the workplace. So thinking about how the workplace in hospital is structured, so rotas, cultural change, physical spaces. And then also when there is an issue, any kind of problem resolution type of intervention. So it could be counseling, psychotherapy, and anything that can help when a problem arises. So, phase one, we developed this typology, and so we did it on a kind of a conceptual level, but also we broke it down as a mapping tool that ideally a hospital could use to understand, to kind of self-assess what they're doing. And we developed this by a very long process which involved analysis of published literature, looking at real interventions in hospitals, and trying to look at relevant theories and incorporating them, and also discussing them with a lot of different partners and stakeholders. So this is actually one of the papers I'm going to mention, so you will find that at the end as well. So this is the typology paper, which has both the conceptual and the mapping tool. I'm going to briefly show you the conceptual typology, because it's quite interesting. So, first of all, I think it's interesting to look at the aims of the intervention. So we try to see what are the aims of the intervention, and then the type of intervention, and also what are the assumptions underpinning the intervention. So we start from intervention that aims to improve the well-being or prevent mental ill health in the hospital or like in the workplace. So this can be divided into workplace improvement or anything that can act at an individual level. But workplace improvement can involve anything that can help individuals, but also teams to have like a more satisfaction at work, better mental health and well-being. Things that can increase personal resources. So anything that can help individuals and teams to have to deal with challenging environments and situations. And then, whenever, as I was saying earlier, whenever there is like a problem, anything that can help to address the specific problem. So whenever there is a mental or a health or well-being difficulty. So that's kind of interesting because it's quite important to place the emphasis on this side of things as well. So thinking about the workplace, how the workplace is structured, if there is anything that can prevent as well stress and promote well-being. So as I was saying, this typology can help conceptualizing interventions into different categories and see, if you're in a hospital or if you're kind of in a different workplace, you can look at it also to see what you've got at the moment and whether you've got anything that can actually, that address the preventative side, that address like any kind of workplace issues that might be a stressor. And because we developed this looking at published literature, we also found that most applications have not clarified the underlying assumptions about the causes and outcomes of any theoretical basis for the intervention. So this typology can help raising the quality of future research and promote clearer thinking about the nature and purpose of interventions. So before you do something, actually trying to do something that is kind of evidence-based. So phase two, as I was saying, we undertaken interviews with staff in these 8 hospitals. And because we were taking this broader approach, our main group of people we interviewed included doctors. That was like the majority. And we tried to be as inclusive as possible in terms of specialty, but also any other characteristics. And there are many different types of roles and ways in which doctors can work in hospitals. I try to cover all of them. I would say like also gender, diversity. But because of the approach, we're also interviewing whoever was involved in designing or delivering interventions in the hospital. So that could include, it varied a lot, but it could include health and well-being leads or champions, medical education managers, line manager, human resources, occupational health. So that's the point. So you need to include all these people in different roles to understand what is happening and how the system issues can be addressed. And we tried as much as possible to interview also leaders and people in strategic roles, because people who have a financial role, for example, they will make a decision about what can and cannot be funded. So I'm going to give you like a high-level overview of the findings. The first one is that, so for doctors' well-being to be supported and to avoid harm, solutions need to align with problems. So a lot of the solutions, like interventions, were not aligned with what the real issue was. Second point, initiatives that involve doctors in creating solutions can better address the well-being problems. The other one was doctors often do not know what support is available to help them when experiencing problems affecting their mental health and well-being. So there were not so much clear information available to them in the workplace. And even if they knew, even if they're aware of what support is available, they can experience physical or psychological barriers to accessing this support. So I'm going to very quickly zoom in each of them. So the mismatch. The well-being interventions in these hospitals was mostly reactive and on things that were not aligned with the problem. So they were not around improving the work environment or basic requirements, which were the issue that doctors were talking about in terms of what affected them. And so the type of interventions included being gifted a tea bag or offered a yoga session or mindfulness training. And this was perceived as being tokenistic or quite superficial. And an interesting, not in a good way, finding is that this not only doesn't work because it's not addressing the problem, but it can actually be harmful because it can basically intensify the issues that doctors are experiencing, but also can lead to frustration and dissatisfaction towards the workplace or towards the employer, in this case, the NHS as a whole, so worsening well-being. Interestingly, sometimes if they work, some of the mindfulness sessions can actually, when they work, they might make doctors realize that they're not doing very well, so they may actually make them leave, so which is not the original intent. That goes back to the point of thinking about the aims of an intervention. So this is one of the cartoons made for Under Pressure 1 by a GP comic artist called Ian Williams. So it was for the previous research, but it still makes sense. So could be a surgery, so there is one doctor saying, oh, no milk again. This is so annoying. And the colleague, blimey, chill out, man. But I've got a huge clinic to get through, and I'm gasping. Maybe we should report this as a critical incident. You joke, but that's not a bad idea. This is a systemic failure. So it seems like a very simple issue, but actually, it's the very small things that are also lacking in the workplace, like having drinks, like hydration available, being able to go to the bathroom. So these are the things that doctors and staff are talking about in terms of things that affect their well-being. Second point, staff-driven initiatives are helpful to address problems, but can be hard to implement. So it's important to enable people to make change. So it's important to listen to the people, like your target population. So whenever there was something that was driven by or co-produced with staff, it was more likely to work. But of course, there is a lot of resistance. It can be bureaucracy, or it can be just difficult to drive meaningful change. So it's important for the environment to be enabling as well, so to create the condition for change to happen. But also, so this is it's an important fine line. If you only ask leaders and managers try to do something, they may act on what they think is the situation, but they may be wrong because they don't necessarily spend a lot of time with doctors or the people who are the population they need to work with. But then you can't put all up on doctors' shoulders as well, because then it becomes an additional responsibility while you're already struggling to deliver the base, to do your job. So I think it's one of the interesting points could be the idea of critical allyship. So thinking about who are the critical allies to involve, because if you frame a problem as being only an issue of the disadvantaged population, then it becomes potentially, as one of the questions, responsibility is only on the how do you say, disadvantaged part of the population. So doctors are best supported when they're clear about what support is available. And of course, they find it hard to access it when they're unclear. So again, some of the people that were involved in deliberative intervention, they thought that the information was all there, was very clear, but actually was not the case. And from the doctor point of view, is because there was maybe sometimes too much, so it was hard to navigate, especially when you don't have time or when you're experiencing stressors as well. So it's not only what you're doing, but also how you communicate is really important. Finally, there are often barriers to accessing support. So this can be physical and psychological. The physical, that's a classic. Whatever session or whatever intervention is not implemented in a way, in a kind of a system, in how do you say, in an organic way that takes into account the workplace. So it's basically unavailable because it is incompatible with shift time, rota. So you offer something which is not possible to attend. But there were also psychological barriers. So support was not always perceived as being safe or helpful. So it may be, like, again, it goes back to the terminology. So it may be like a counseling or psychological, and it may come across as being too much of a big deal. And then there are also like professional and interiorized stigma, or rather like perfectionism as well. So some doctors worry that asking for help may affect how they're perceived as doctors. So there were also other very, say, frustrating situations where there were people who managed to access, for example, therapy. They find it quite helpful. They find it safe only if it's like if they can access it in their own terms, but not if it's forced. Sometimes it was also like too short, so there was kind of starting addressing an issue and then the session had to end. So, and this is another cartoon exemplifying the access point. So there is a doctor who is trying to book a session. So, hello, I'd like to join the yoga session for staff, please. Tuesday, 2 p.m., I have a consultant who around then. Do you have any other times? No. Okay, thank you. And you can see this is also, can increase frustration and dissatisfaction as well when there is no way to access the support that your workplace is offering. So in summary, I think you're still here, yes. So despite there is growing focus on workforce well-being, but the problem continues and actually to a certain extent is not improving. Linking to the point that understanding how to support doctors' well-being at work is a value in itself, will benefit doctors, but also has huge implication in terms of delivering equitable and excellent care. So it goes back to the point I was making in the beginning, there is no health without a healthy workforce. There is often misalignment between what doctors perceive to be the problem for well-being and the solution offered. And this misalignment is not only neutral, but can cause harm to well-being, leading to feeling of frustration, cynicism, and feeling undervalued. So that's quite interesting. So doctors are mandated to do no harm to their patient. And I think it could be quite an interesting thought to extend this to doctors themselves. So before implementing, so if you are implementing, and you know it very well, if you're doing clinical trials, and before implementing something, there are a lot of very rigorous checkpoints, whereas a lot of interventions that are offered are poorly designed and not necessarily evidence-based, and can actually cause harm. So initiatives that need to target the issue in the work environment that creates the problem. And this can, trying to listen and involving or enabling doctors and other staff to make changes is more likely to help. And of course, the more you do that, the more you improve the working experience of doctors, the less the number of doctors might need intervention for serious well-being related problems. So that the individual level can be more focused as well. And workforce well-being is often been seen by leaders as an optional extra, like an add-on. That's the initial point that Sandra was making. Rather, so being at the end or not being central, but it's actually it's not an optional extra. It's just the very core. It's a basic thing to be able to work, to deliver care. And this kind of finding are in line with the previous work also on focusing on nurses, midwives, and paramedics. So system-level approaches are required. And because of the things we're talking about are really work environment, systemic issues, there are more similarities than differences between the well-being experiences of different care professionals. So the nurses, midwives, and paramedics, evidence synthesis found similar need for system-level approaches. So I think that's it. So I just wanted to, as I was saying, you're very welcome to look at, Ian Williams made also like an animation to translate our findings from the previous calendar pressure one into something that can be used to make a point across. We also made a video asking patients, like people, why is the health of your doctors important to you? And that links to the point I was making earlier about no health without a healthy workforce. So people were saying, there was no script. I just got somebody to film and ask people, why is the health of your doctor important to you? And they said things like, I want to get an appointment quickly. I don't want them to cancel my appointment. A rushed conversation doesn't help my doctor to understand my situation. A tired, overworked doctor can make errors. Doctors have a right to good health too. I care about my doctor. So this thing can be useful to, if you want to use them as well. And just the references, you will have them in the slides. I think that's it. So thank you very much.
Thank you very much. And if there's any question?
Yeah, well, maybe I start with a question. You mentioned that this poorly executed well-being attempts like the occasional tea bag and yoga sessions are actually making things worse. How can people communicate that this actually makes it worse? Because, I mean, if I approach my employee and say, well, you're giving me free yoga lessons, but that's not helpful, people might be perceived as ungrateful. Do you have any recommendations about that?
So I think it's because it's we are part of the system. So first of all, it's kind of hard. How do you start? So if there is already like dissatisfaction, you need to do a lot of work to gain trust back. So from a manager point of view, whatever you do, it's unlikely that it's going to be perceived positively. So it's not just the individual, but you can, as an individual, you can speak to the critical allies. So it can be your education mentor. Can be in some hospitals there are these new roles that are like well-being champions or guardians. Sometimes they're helpful, sometimes they're not. So you need to find the right people. So what we are trying to do is also to communicate our findings. So we've been speaking with a lot of stakeholders throughout all the projects to understand who are our audiences, so who to speak to in order to help that. So people have been mentioning the hospital board. So I think that the short answer is that a lot of things need to happen, so you need a kind of multi-pronged approach. And speaking to different people at different levels at the same time. And if you are on the other side and you're trying to implement something, it's very important to, to do some meaningful engagement before, to understand what are the real issues and trying to be able also to do that when you're ready. Because if there is a listening exercise that is not accompanied by any action, can even be worse. So it's kind of being quite strategic. From a management and from like a system level point of view, there is a lot of evidence, and there was also from the pressure one, that so feeling isolated is the highest stressor, and something that can intensify any kind of stressful experience at work. Conversely, meaningful connection, anything that makes you feel that you belong to a team, to your profession, to the place, is the best buffer. So if you're trying to create opportunities for meaningful connection, but it needs to be meaningful, that can in itself start acting as a buffer. And if you connect to other people, you can quite quickly also understand who might be other key players who might help you, because if you just do it yourself, it's not gonna, as you know, also from your scientific and clinical experience, healthcare systems are very fragmented and they tend to operate in silos. So you need to find the critical allies in the specific workplace as well. Sorry, it's a very long-winded answer, but it's because it's quite complex.
Thank you very much for the great answer. Are there further questions? Yes, please.
Yeah, thanks. Hi, I'm JB. I'm from Singapore, quite far away from Europe. I hold dual hats. I'm an associate program director, and I'm also a late career PhD student. So I kind of can see things from both sides. But thanks for the wonderful talk. I guess one main question I had for you is, what were some of the interventions that brought you the most bang for your buck?
Sorry, the intervention that
had the most bang for your buck?
So, again, I want to resist. So I can give you examples. Things like, so there was a problem of trainee doctors feeling isolated, especially when they were doing night shifts. And then like a midnight huddle was introduced so that they could actually connect with other people once they knew that was happening. So that's an example. To be fair, there were, in this kind of pressure too, there were very, very few examples of things that worked. But this, I don't want to give you the idea that if you do that, there is also the whole point of scaling up and transferability. So I was mentioning the realist approach earlier. So there is no one size fits all. So it's more around following, it's similar to a code of practice. So there might be some principle, and the principle can be anything that, for example, that can promote meaningful connections. Anything that is implemented in a way that involves real engagement. But also, it goes back to the previous question. So there were some questions from representative of like PhD or science lab and then a PI. It's all disconnected. So the more you try to create, like to break these silos, the more likely is that you will lead to some meaningful change. So if you tell a PI you need to be better at listening to your PhD students, but you don't give them any kind of tools or any real ways to do that, well, they may just feel worse. And they may, so it's like thinking about who are the stakeholders, what are the issues, what is the evidence base that can help, and how can I implement it in a way that takes into account the specific issues. Sorry, does it make a bit of sense? Or
yeah, it does. I guess it's also maybe a question to everyone here as well as the panel. What were the small steps that have been successful that you've tried? And sort of each small step combined together can make a really big step.
So one small step is linked to, I believe that, first of all, seeing that this is not your problem, but that is a systemic issue, might in itself be helpful because you feel less responsible and less guilty. But the second thing, that is the only thing I can say at the moment, there is a lot of evidence, as I've been saying, that the more you feel like meaningful connections, so you can create a network of peers, and then you can expand. And honestly, there is another project that is related to current under pressure that is about shared social spaces in hospitals. Everything is going in the opposite direction. So there used to be many more safe social spaces. There could be the doctor's mess or some like places where staff could spend time together, not shared with patients. And these are increasingly disappearing. In the UK, I think also in other countries. So even having, like trying to stop removing shared social spaces and repurposing for something else, but keeping literally like physical space where people can gather and do you say have spontaneous conversation can be very potentially could be quite important, not only for the well-being, but can also be an opportunity for learning. It might be an opportunity for for sharing ideas. I mean, this is not. This is something that is ongoing. So there is there is a scoping review published in the Medical Education, which is the main medical education journal, on the role of shared social spaces. But that's kind of based on literature. There is a current study that is actually looking at hospital spaces and trying to understand whether they have a role on well-being and learning, for example. So what, if you go on the calendar pressure website, you'll see that there is some evidence-based guidance, and they are principles formulated for doctors, policymakers, managers, so trying to think in their language. So, and there are principles about how you can either improve an existing intervention or design a new one. So I think that can be quite helpful. Yeah, I can't do it now, but if you go on the Calendar Pressure website, Calendar Pressure Exeter, you will find like resources. There will be some like a guidance.
Any other questions? If not, then I just have one. So how do you recommend PhD students to approach to their mentors, like to their PIs, especially some of the examples that we heard before, like my life has been hard, then your life is going to be hard. How do you recommend to live with that and to communicate with that kind of approach?
I would answer this question not as a researcher, but as a senior lecturer involved in working, because this is, I can't, it's hard to make a broad statement, but I think in the UK, my perception is that universities are slowly trying to offer well-being support. For PhD student, there is a crucial role, that is the mentor. The mentor is not a PI, the mentor is not a supervisor, but is an additional person that is supposed to deal with what they call like pastoral or any kind of well-being issues. And it's key that it is not the PI and it's not the supervisor, because it's just a question of conflicting roles. So in medicine, I think it can still sometimes be the case that the person you might ask for like a pastoral well-being support would also be the person that at some point might evaluate you. And this is not very constructive. So I think in the way PhDs are structured in the UK is that there is this additional person, there is the mentor, and the mentor should be the person that can, first point of contact, but then the mentor themselves, normally they're not trained to provide support, they're not trained to provide specific support for neurodivergent students and so on. So there are additional entities that the mentor can signpost the student to, and there are kind of well-being supports within the university. But there is kind of a welfare, well-being. Sometimes there are very complex issues. There may be issues related to housing or personal circumstances. So you need also to link welfare. So I would say first port of contact is the mentor, but the mentor is not crucially. It's a different sphere. So PI, supervisors is PhD work, and the mentor is more like personal well-being issues. Sometimes, you can, depending on how you feel, you may feel safe enough to speak to your supervisor, but I think in a lot of circumstances, it's probably much better to have somebody who is not connected, because then if you need to work with them for a long time, you might feel uncomfortable yourself if you share personal issues, but you might not want to do that in the first place. So that's the main issue, that why there is a separate figure.
Okay, thank you so much then. If no other questions, we don't have online questions, then we will close this session. Thank you all for being here. Thank you, the online attendance. Thank you, Dr. Carrieri, very much. Thank you all for being here tonight.